Good afternoon, everyone, and welcome to the FEMS Public Health Educators in Medical Schools Special Interest Group webinar. My name is Richard Pinder. I'm one of the public health doctors at Imperial, I was going to say Imperial College, I'm not sure what we're called anymore, but Imperial School of Public Health. And I've got my colleague Anna, and we'll do an introduction in a second on that. For all of you who are joining, I hope many of you are from the FEMS Special Interest Group. I think we've also got colleagues from the Academic Public Health Special Interest Group, and of course, lots of guests as well. And I do hope that we'll be able to share some of our learning and reflections towards the end of today's session. And just so you're all aware, there is a chat function, which I think you can all access. So please do feel free to sort of heckle or pose questions as we're going along. That's in the chat. And just further sort of housekeeping purposes, today's session is going to be recorded. The presentation segment is going to be made available online, but very kindly, Heather, who's from the Faculty of Public Health, who is helping us out, will be stopping the recording after the presentations to hopefully allow a little bit more free-ranging discussion and points to be made in the final quarter. So what are we doing today? We've got three presentations of about 12 to 15 minutes each. The first is going to be on the essential public health functions, and my colleague Dr. Jack Haywood is going to be presenting that. He sent a recording, so we'll be playing that in a second. I'll be saying something about challenges and opportunities for public health in medical education. And then the final section will be looking at a little bit of a case study from my colleague Dr. Anna Ogier, who is coming from Imperial as well, to talk a little bit about her experiences as a clinical teaching fellow in lifestyle medicine and public health this year. And on that note, Anna, do you want to introduce and say hello to everyone?
Yep, so hi everyone, my name's Anna. I'm a junior doctor who's in my FY3 year. So I've spent this year as a clinical teaching fellow at Imperial within the School of Public Health. I'm really passionate about public health and medical education, and I'm really looking forward to sharing with you all my experiences of teaching on a course called Lifestyle Medicine and Prevention.
Thanks for that, Anna. And like I said, guys, please do feel free to put questions and raise points in the chat. We'll come back to those as we go along. But without any further ado, we'll move on to Dr. Jack Haywood, who's been doing this work in collaboration with NHS England and the WHO Collaborating Centre at Imperial. And fingers crossed this works.
Thank you very much, Richard. Firstly, I'm sorry I can't be with you today, but I do hope that you enjoy the session. My name is Jack Haywood. I'm a Public Health Specialty Registrar in London, and I was part of a research team in NHS England who worked with the WHO and other partners on developing a competency framework for the essential public health functions as part of the Public Health Roadmap. Before going into the detail of the framework, I wanted to provide some background on the EPHFs. The WHO has proposed a unified list of 12 essential public health functions, primarily the responsibility of national governments, which should be delivered at national and subnational levels, by public and private sectors, by communities and individuals. These functions can be operationalised through health programmes and services according to country context, including population health needs, priority risks, and local approaches to assuring health protection and delivering health services. The vital role of the public health workforce in implementing these essential public health functions cannot be overstated. However, in some cases, individuals tasked with delivering these functions lack the necessary skills or training, while those who do possess them are under-recognised and underutilised. Additionally, the significance of public health is often not fully acknowledged, further contributing to this issue. To address these challenges and strengthen countries' capacity to operationalise the essential functions, a comprehensive and collaborative effort is essential. Building from the 2021 G20, the WHO and leading public health institutes collaborated to develop a roadmap entitled The National Workforce Capacity to Implement the Essential Public Health Functions, including a focus on emergency preparedness and response, roadmap for aligning WHO and partner contributions. The roadmap envisions a strengthened workforce in every country, delivering all the essential public health functions, including emergency preparedness and response for universal health coverage, health security, and improved health and well-being for all. The approach to strengthening the capacity of the public health workforce and delivering on this vision is oriented to 3 interlinked action areas. Action Area 1 is to define the EPHS, their sub-functions and the programs and services needed to operationalise them. Action Area 2 is to identify the skills and competencies required to deliver these functions and services and develop a suite of competency-based education tools to deliver the functions and services relevant to role responsibilities and context. And Action Area 3, which is to map and measure the size and profile of the range of occupations engaged in delivering the essential public health functions. The focus of the remainder of this discussion, unsurprisingly, will be on Action Area 2, which is a competency-based education. Now, the workforce that delivers the essential public health functions comprises all individuals who contribute to the delivery of at least one of the functions. This workforce therefore includes people with diverse occupations in the health and other sectors. We can classify the public health workforce into the following groups. The core public health personnel, that centre circle. These personnel work almost exclusively on the essential public health functions. They may have undergone specialised professional public health training, such as a specialist registrar programme in the UK, or be registered with professional public health bodies, and they may have either a health or a non-health background. Their work may contribute to multiple functions or specialise in one function. Such personnel could include epidemiologists, public health consultants, surveillance officers, and directors of public health. There are health and care workers, and this group includes personnel from the health and care workforce who spend some of their time delivering the essential public health functions in the course of their usual clinical or social care tasks. Examples include nursing personnel, medical doctors, midwifery, community health workers, and social workers. And then there's occupations allied to health, and this group includes a wide range of allied occupations outside of the health sector that play critical roles in addressing the determinants of health. Examples include personnel engaged in animal health, urban planning, water and sanitation, food supply chains and transport, etc. The Global Competency and Outcomes Framework for Universal Health Coverage, which aims to advance improvements in health and progress towards universal health coverage through aligning health worker education approaches with population health needs and health system demands, defines competencies as the abilities of individuals that underpin effective performance of tasks and represent the integrated and applied knowledge, skills, and attitudes demonstrated through behaviours. Specifically for meeting this aim in the essential public health functions, the WHO and partners analysed existing frameworks and resources and developed a competency framework defining the practice activities and competencies for public health and emergency workforce to deliver the 12 essential public health functions. This is the Competency and Outcomes Framework towards the delivery of the essential public health functions. And this framework is due to be published by the WHO in the coming weeks. So I'm going to explain a little bit about this today. It can be used by educators, educational institutions such as the Faculty of Public Health, employers and regulators. It can also be used to review, benchmark and strengthen public health education and training to meet national public health requirements. So before looking at some of the detail of the framework, it's worth exploring some definitions and concepts. So competency-based education is a form of outcomes-based education rooted in mastery learning relating to work performance, which can effectively prepare the workforce for public health practice and emergency management. Competency-based education is a whole of education programme approach, encompassing competency-based outcomes oriented to health needs, the progressive sequencing of learning experiences tailored to competency-based outcomes, teaching tailored to competency-based outcomes, and the programmatic assessment of the achievement of learning. And there's lots of evidence out there looking at competency-based education as a tool of learning. Now, practice activities are the core functions of public health practice. They comprise groups of related tasks, such as interpreting surveillance data or planning a public health programme. These activities are widely used for workforce planning and for the definition of occupational groups and job descriptions. However, the provision of public health programmes, services and emergency management requires not only the performance of discrete or sequential tasks, but the ability to adapt practice, make informed judgments, navigate health systems, and collaborate with individuals, the population, and other organisations. And this draws on a person's competencies. Now, competencies are a person's ability to integrate knowledge, skills, and attitudes in their performance of tasks as needed for the context. Competencies are durable, trainable, and measurable through behaviours. So practice activities differ from competencies in that they can be observed from start to finish, they are time limited, and they are measurable through the performance of tasks, and they are not attributes of individuals, but of work. Individuals may be certified to perform practice activities with the relevant specifications. The competency-based performance of practice activities is the focus of education oriented towards employment. And this behavioural competency model is illustrated on the slide. So when a public health lens is deliberately applied to the education outcomes of a learning programme and oriented to employment requirements, competency-based outcomes frameworks will provide a common language for educators, employers, and regulators. In this framework, the essential public health functions and the programmes and services required to operationalise them offer this public health lens, and the range of competency-based education outcomes are identified in relation to them. From these outcomes, the foundational knowledge, skills, attitudes, and values can be identified. So this framework was developed between November 22 and June 23. The core research team was made up of colleagues from the WHO, NHS England, which is a WHO collaborating centre for human resources for health, and Imperial College London, which is a WHO collaborating centre for public health education and training. The aims of the framework are, firstly, to bring together and build on existing frameworks and resources to strengthen education programmes through the lens of a common conceptual model for competency-based education. 2, to define the practice activities required to deliver the essential public health functions, encompassing the breadth of the public health workforce. 3, provide a modular foundational tool to adapt and adopt and to guide the strengthening of competency-based education approaches, combining the art and science of public health and linking academic and technical skills with the competencies needed to deliver the functions. And 4, guide a consistent and concerted effort to align education programmes with employment throughout the lifelong continuum towards the delivery of the EPHS. The content of 31 frameworks were analysed in full. Drafting of the framework was carried out before the content was validated against another 95 frameworks. The drafting was iterative and integrating insights from the content analysis of existing frameworks and feedback at each stage by the technical advisory group and consultation. The structure of the framework is as follows. The first chapter gives the background, which highlights principles of public health, introduces the roadmap and the essential public health functions, and gives the academic and operational principles, expanding on what I've already talked about today. The second chapter describes the competencies and behaviours outlined for the public health and emergency workforce through the framework analysis. The third chapter describes the practice activities and profiles to illustrate these. And the final chapter gives guidance on how to adapt and adopt the framework in different contexts. So looking at chapter 2, this identifies 20 interrelated competencies essential for public health practice organised into 6 domains: community-centredness, decision-making, communication, collaboration, evidence-informed practice, and personal conduct. Together they form a theoretical framework for describing good practice relevant to all the essential functions and the whole public health workforce. Core public health personnel, health and care workers, and occupations allied to health. This chapter also identifies the behaviours that demonstrate these competencies, as well as additional leadership behaviours, forming a theoretical framework for good practice rooted in the ethics and values of public health. The competencies and behaviours are relevant for the whole of the workforce at all career stages and for the range of practice activities and tasks. The way in which these competencies and behaviours are demonstrated in practice varies between individuals according to their role responsibilities and, importantly, the context. For example, all effective public health practice should be rooted in evidence. Some health workers follow guidelines or protocols formulated in evidence, while others will balance different types of evidence to make complex and contextually relevant decisions. Specific behavioural indicators must be elaborated to contextualise competencies for different practice activities and contexts, and to inform education and practice standards. And this shows an example of the competencies as laid out in the guide going forward. Chapter 3 provides a reference list of 40 practice activities that operationalise the essential public health functions, when contextualised to public health priorities and settings. Collectively, the set of practice activities is relevant to the whole range of role responsibilities of the public health workforce, and this is unlike most education programmes, which are typically oriented to a subset of role responsibilities for a specific occupational group or context only. The set of practice activities does not define what should be in a curriculum or indeed in role responsibility. Instead, it offers a map of the different practice activities for consideration. This chapter therefore provides a modular curricular guide to be adapted and adopted alongside the competencies and behaviours outlined in the previous chapter. The 40 practice activities are organised into 5 domains. The systems building blocks for public health, such as workforce planning, physical infrastructure and quality assurance. Intelligence about public health risks, threats and health status, including data collection, surveillance and monitoring, and risk communication. Public health programmes and services, informed by intelligence about public health priorities and encompassing planning, stakeholder collaboration, delivery, monitoring, evaluation and continued quality improvement. The management of resources, including human, physical and financial for those programmes and services, and emergency management across the spectrum of prevent, detect, respond and recover. And in the same way that the essential functions are interrelated, so too are the practice activities. Of course, although broad in scope, these practice activities alone will not deliver the essential functions, and their full achievement requires inputs from across numerous sectors. To support the development of curricula, the framework sets out 5 elements for each practice activity. The public health impact statement, a brief description of the linkages with the essential public health functions. The sub-functions of the essential public health function, which are operationalised by the practice activity. The range of tasks needed for the practice activity for contextualisation. Indicative tasks for the 5 illustrative profiles. And a curricular guide with key areas of knowledge and skills linked to the tasks within the illustrative profile of the practice activity. Operationalising the action areas outlined in this roadmap requires the support of a broad coalition of partners and stakeholders with diverse expertise and collective collaboration and action from governments, funders, technical partners, academic institutions, and so on. So this roadmap calls upon all these partners to work together to form this public health workforce and equip them with the skills that they need. So to end, a big thank you to the Global Technical Advisory Group for Competency-Based Education, which was convened to guide the development of this framework and provide technical advice on the content, organisation and language used. And also a big thank you to the WHO for the coordinating and leading role in the development of this framework, and my colleagues at NHS England and Imperial College London for their contribution. As I said before, the framework is due for publication very soon, so do watch out for it. In the meantime, I am very happy to take any questions or comments by email, and my email is on the slide here. I do hope you enjoy the rest of the session, and back to you, Richard.
Well, thank you very much, Jack, and welcome to those of you who've joined us a little recently. So we've started off there with perhaps the widest possible look over.
Thank you very much, Richard.
No, oh, I pressed the wrong button. Apologies for that. Let me just go back to sharing the screen. So we've started off with the widest possible lens on the what of public health. And I think for many of us working in public health, it remains a question as to, well, what is it that we're actually teaching? And then also, is that potentially relevant for us as medical educators, is what is the basic curriculum that we need for doctors? Or at least medical students. Is that working, everyone? Apologies, I shouldn't have pressed escape there. I've learned that from my next point. So thank you very much. So following on from that first presentation from Dr. Haywood, which is examining the what of public health education in its broadest possible sense, and in particular in that context of that wider workforce, we're going to move on to my presentation, which is going to address perhaps a little bit more of the why before moving into Anna's presentation, which will be looking at the how. And I want to ask forgiveness for those of you who are full-time medical educators in public health at the moment, because I will be trying to bring everyone up to speed, given the diversity of our audience around some of the drivers that we're seeing, certainly in the UK at the moment, and some of the challenges for medicine more broadly. Now, we are talking in particular about doctors and medical training. So please forgive me, we are the Public Health Educators in Medical Schools group. But for those of you who remember their public health education at medical school, there are two statements that I sort of wanted to flag with you to begin with, which certainly resonate for me in terms of my experience or recollection, or indeed lack thereof, of public health and epidemiology teaching whilst at medical school. And here's one from 1960, first of all. Teachers of epidemiology need to be both unusually optimistic and to utilise any available aids or methods which might facilitate their task as educators. So it's always been the case, I think, that certainly teaching epidemiology and what used to be referred to as social medicine, which I think today would normally describe as public health, referenced in the Todd report in 1968 as social medicine being dull, neither useful nor difficult. I'm not sure if that is something that potentially resonates with you, but it certainly did with me. And so when 5 years ago I was asked to come in and try and redevelop our public health or population health curriculum at Imperial, it was interesting to reflect on both my own experiences, but that actually perhaps they weren't all that unusual. Now, huge credit to colleagues Ellie and Barty, who are on the call today, who I'm sure will say hello at some point, have been leading this consensus statement, which for those of you who are potentially new to public health education in medicine, is certainly the go-to reference for a consensus statement on what does constitute a good curriculum for medical students, recognizing, of course, that challenge of a specific, let's say, group of people who want to do an MPH is quite different to a group of, certainly in this country, 18 or 19-year-olds who are embarking on becoming a clinician. Really trying to identify them, the sort of the center point of what we need to deliver is a challenge. But there are a number of intrinsic drivers of sort of pushing the population health agenda within medicine. And I'm going to use the phrase population health hereafter, because that's what the GMC outcomes for graduates, for those of you who are similar generation to me, that's the new replacement for tomorrow's doctors, which specifies population health as a specific set of competencies that need to be achieved through medical school. And of course, for those of you working in England, you'll be very familiar, I'm sure, with the NHS England's long-term plan back from 2019 and the wider prevention agenda that has had certainly a lot of traction. The extent to which it has been successful, I think some of us might call into question. But there's no end of people who at least at face validity are saying prevention is important. But of course, beyond those sort of intrinsic drivers, there's also a number of extrinsic drivers, and certainly the experience for those of us who at least were able to stay a little bit of time in education during the pandemic, when many of us were pulled back into service public health. We've had a pandemic, we've got big data, we've got machine learning, generative AI, and that sort of potential to exploit electronic health records and think about things like population health management is more salient than perhaps it ever has been. But there are uncertainties too at the moment. If you have been looking at Twitter, X, or have been following any of the medical media, certainly over the last 12 months, the challenges, and I've pulled up two Royal Colleges there, Physicians of London and GPs, and then also the Academy of Medical Colleges have been singled out for a great deal of criticism from the profession as a whole. We'll come back to the NHS long-term workforce plan in a second, but just to sort of update you on some of the things that have happened over the last couple of years that are relevant to us as public health educators in medicine. The first one I'd sort of emphasize, the top-down change, is the push towards a 4-year medical degree as a default. Now, that doesn't necessarily mean that all medical degrees will have to be 4 years, but certainly new medical degrees, the expectation going forward is that they probably will be 4 years. And for places like us at Imperial, where actually we have a default 6-year MBBS BSc program, there are very major challenges and questions that are posed. And I'll come back to that in a second. We've got the medical apprenticeship system, which is starting relatively soon. And that means that people are going to be trained in medicine in 4 years alongside a quasi full-time, part-time role within the hospital setting. And we've got medical associate professions, physician associates among them. And collectively, these are calling into question, I think challenging a lot of the assumptions or presumptions that we make around how much time there is for medicine, or indeed what it means to be a doctor. But on the bottom-up side of things, we have to be mindful too. And it won't be far from any of you who are working in this country or working in the NHS to observe the dissatisfaction and the low morale that we see around us, which, although potentially as consultants like myself, we sort of see a little bit of, the lived experience of medical students and of junior doctors really is, from what I can see, markedly worse than it was when we were in their role. And of course, there is the generational changing of attitudes in terms of expectations about work-life balance and what's acceptable. And if any of you are interested or curious in this, I found this really interesting and perhaps a very poorly timed tweet, which Health Education England, now gone, put out last year, 28th of March 2023, which asked people to celebrate their 10-year anniversary and talk about what HE had done for them. And if you get the opportunity to read some of the quite harrowing details, perhaps slightly flippantly put by junior doctors of their negative experiences of HE, that certainly took over that thread and gives you an indication of this sort of deep uncertainty and concern that we're facing at the moment. Now, I said I'd come back to the NHS long-term workforce plan. And for those of you who haven't looked at it, I would strongly urge you to read at least the executive summary. It's an absolutely fascinating document, which I was actually genuinely impressed with the level of analysis and the projections and forecasts that they're making. I've pulled out one waterfall chart, partly because I love a waterfall chart, but just to give you an example of the challenges that we're facing over these next 15-year period. And the long and short of it, without necessarily going into the diagram, is that we are going to be massively, massively short of doctors and indeed of almost all healthcare professionals. Public health as a specialty is referenced in there. We're sort of scheduled for a slight uplift in terms of workforce, in terms of specialty training. But the deficit is really, really challenging. And even if the most optimistic estimates of NHS England play out, which I think is almost certain not to happen, the gap that we have in workforce capability and capacity, certainly over the next 8 years, is going to be very, very profound. And if the best estimates do happen of increasing workforce and pipeline within that, there is still a very difficult several years in between. And what I try to say to medical students and to doctors about this is that there will be no shortage of work, no matter how concerning it might be around associate professions and everything else. And of course, we've gone through that agenda to some extent already in public health with a much more diverse and blended workforce than many of the other medical specialties. So there's certainly some learning that we can take from that. But really just to emphasize the gaps. And here's another table of the sort of detailed gaps that we have in medicine overall. What I really want you to take from this is not necessarily to look at the numbers, but to realize this is very much a burning platform. There is a lot that we have to do. And there is a lot of uncertainty and deficiency across the system that we need to be mindful of. So what does this mean, as I go into my last 2 minutes, for the average NHS doctor? Well, I think many of you who are working around the country and maybe spend a bit of time in healthcare settings, as well as your public health practice, will be suspicious of the idea that the future NHS doctor, certainly maybe 2035, is more generalized, less hands-on clinical, because there will be other people who to do those roles. If you spend any time in North America, you'll be aware of the huge range of associate professions and technologists who do a lot of the stuff that traditionally as doctors we have done. I would argue the future doctor is going to be more thinking, more sort of augmented CDSS type work, leadership, potentially less exclusive to the NHS, although that's certainly something that you guys might want to question, and with greater engagement with third-party organisations. This idea of this movement towards a portfolio career is something that we see massively around us, and certainly seems to be the direction of travel for many of our graduates. So what does this mean for medical educators? Well, GMC did put out a blog a few weeks ago that attracted quite a lot of criticism, some of it, I would argue, quite unfairly, around the changing nature of medical knowledge, the ability to look on Google and to find information that sort of historically my generation would have been forced to have as sort of knowledge that we could just simply recall. I think there is a basis to that. But the need for future doctors to manage greater complexity and uncertainty is there, to be able to relate to people, to be able to clarify hierarchies and collaborate. These are all things that we've been talking about in medical education to some extent for the last 20 or 30 years, but they're more important and salient and potentially, rapidly approaching than they were before. But let's go back then to what does it mean for us as public health educators? Well, I would argue that actually a lot of those skills are competencies and approaches that we take for granted as public health experts. And they are something that I'm not sure are necessarily widespread across many of our other more transactional and clinically oriented craft-based specialty colleagues. Outside the senior leadership of medical schools, the ability of our colleagues to actually understand what's going around in the system, I mean, even in public health, we struggle with this. We have a unique position, capability and understanding of that broader system. But there are massive challenges to what we're doing over the next several years too. This move towards 4-year curricula, well, where are you going to squash stuff? There's only so many summer holidays you can potentially cancel within that. And we need to be really mindful as public health educators to really think about where does population health fit in a reduced, consolidated, less space and time, curriculum space and timetable. We have a real challenge around workforce. I know Kevin Fenton, the president of Faculty of Public Health, was on a blog a few weeks ago regarding the contractual differences in remuneration issues that we have even just across the profession. And there are comparatively few people who are doing both service and academic public health, which is a real challenge. So where are we going to find these people to lead education is a big question. And then there's the wider question as well, which, we're all public health, we like wider questions, is that where is the population health teaching for other clinical specialties and other disciplines? And I don't know where that is, but if anyone's got any experience of that, it would be great to hear it. So what are the implications for public health educators? Well, my argument would be that that idea, that Todd report, it's neither difficult nor interesting or something along those lines, is that we've got to be able to teach public health and population health in a much more applied context. There are only so many ways you can explain that there are inequalities and this is what it does to health span and lifespan. Being able to contextualize some of those experiences for doctors is going to be absolutely critical in terms of enabling them to effect that system change later on, whether or not they want to become public health consultants or see it as part of their wider scope of practice. We need to confront the pressures that are created by 4-year degrees because there is a risk that there is a race to the bottom, and population health in terms of the things that are going to pass you the assessment at the end is going to be a challenge. I should have actually said that the medical licensing assessment, which is a national licensing exam that will be taking place from spring 2025, is something, if you're not aware of the MLA, the medical licensing assessment, creates a sort of a national finals process. So do look that up if you're interested. But we also need to create a firmer pipeline that shares workforce between service and education settings. The more education and the more academic time I spend, the more I miss my service practice, and that's a real challenge too. So I hope I've been able to just very quickly there give you an example of some of the things that are going on in medicine and also some of those drivers that I think are important for us to consider going forward to think around where does public health and population health fit in future curricula. And at this point, I'm going to hand over to my colleague, Dr. Anna Ogier, who's going to give us her perspective and her experience of what we've been doing at Imperial to deliver population health. Anna.
Thank you very much, Richard. For those of you who just missed the introduction, my name's Anna and I'm a junior doctor who's working as a clinical teaching fellow at the Imperial School of Public Health. And as has been outlined, there's clearly a need for incorporating population health into the medical curriculum in a way that has got clinical significance for medical students who are going to become our future doctors. But how do we do this? So I'm going to outline how the Imperial School of Public Health took on this challenge through the creation of an innovative new module back in 2019 called Lifestyle Medicine and Prevention, or LMAP. So during a curriculum review at the Imperial College School of Medicine, it became apparent that increasing mental health support needs among students and rising NHS service pressures alongside staff burnout were real-world drivers which necessitated a fresh approach within medical education. And this is where lifestyle medicine and prevention comes in. Lifestyle medicine, an evidence-based approach looking at behaviour change and the impact of lifestyle factors on health outcomes, provided a unique vehicle to communicate key topics in population health in a clinically relevant way for medical students, whilst also providing an opportunity for students to reflect on their own health behaviours. So next slide, please. So in terms of LMAP's sort of triple aim, these are summarised in this diagram here. So the first being building knowledge, understanding and skills in lifestyle medicine. The second, fostering a population health mindset. And thirdly, developing insights into students' own health and well-being. And as you can see, these three aims are all interconnected. And in terms of how we go about trying to achieve these aims, just next slide, please. Obviously, these are quite big aims of being quite ambitious, but logistically how LMAP works, this is a module that's delivered to both first and second year medical students at Imperial and occupies roughly 15% of the curriculum in each year. The emphasis on first year is laying the foundational knowledge on key lifestyle medicine pillars, so sleep, nutrition, physical activity, mental health, finances and health, with a focus on individual behaviour change through a combi approach. And this culminates in a podcast assessment in groups where students demonstrate their knowledge of behaviour change. This then leads into the second year, where they build upon this knowledge with tutorials on epidemiology, health coaching, a life course approach to population health, while incorporating insights into global health and policy making. Again, this allows students to apply their knowledge of lifestyle medicine and behaviour change to a wider societal level. The content's delivered through a student-centred approach using a flipped classroom. So students carry out a lot of the didactic content at their own pace at home, and then they come in for in-person small group teaching that consolidates that learning. The module is very much clinically driven in its content and also clinician-led, with junior doctors and public health specialty trainees primarily delivering the tutorials. As you can imagine, delivering a module with such a diverse subject matter has not been without challenge, with the tutorials constantly evolving in an iterative process. Furthermore, the term lifestyle medicine itself can be met with some skepticism from both students and other professionals alike. But I'm hoping, as I now go through some student feedback with you, we can demonstrate to you how lifestyle medicine and prevention has actually been a really valuable tool for students in a multitude of ways. Next slide, please. So in terms of what do students think, we asked medical students at Imperial who completed the teaching in first and second year in LMAP to carry out some questionnaires and also participate in optional focus groups. Their responses were analysed using thematic analysis, and three key themes emerged. The first is how LMAP has altered the students' perception of medicine. The second is how LMAP has affected the students' understanding of the role of a doctor. And thirdly, how LMAP has impacted students' own behaviours. Next slide, please. So in terms of how their perception of medicine has changed, students have really recognised the importance of a lifestyle approach in medicine and its role in providing a holistic and patient-centred care. So as one student said, I think whenever I thought of a doctor, you treat the symptoms, you treat them and you discharge them, or you send them back with medication and hope it improves. But I think there's so much more you can do. Have you reviewed their diet? Have you reviewed their physical exercise? Have you tried to target what your problems were before? And by just going one step back, have you really tried, is what I'm left with LMAP. Have you put a plaster over it, or have you really tried to fix the wound? Furthermore, other students have also recognised the importance of understanding behaviour change techniques as part of providing effective treatment in medicine, as well as the importance of a lifestyle medicine approach being particularly valuable in complex patient cases, such as in multimorbidity. Next slide, please. Furthermore, the second theme is how the role of a doctor has changed and been shaped through LMAP. Many students have integrated key population health concepts, such as tackling health inequalities and the wiser determinants of health, into the role of a doctor. Students have shared how they view the role of a doctor as an advocate, and they have a role in addressing inequalities that exist. How they have to take a wider responsibility in terms of public health, and that a doctor must understand that health varies greatly on the basis of where someone lives. Furthermore, a student has explained how they viewed prevention as key to their role of being a doctor. It's moving a doctor away from just fixing the issue when something goes wrong, to also preventing the issue from happening in the first place. I personally find these quotes really encouraging and as evidence of successful integration of population health into a medical curriculum. Next slide, please. Regarding the third theme, the shaping of student behaviours, this is really fascinating and demonstrates to me how LMAP has inadvertently become an intervention in of itself to medical students that pays both dividends for both the students, but also their wider peers and families. As one student said, "I've been completing fitness challenges on YouTube and completed the longest hike I've ever done after I submitted all my LMAP work. I'm feeling really inspired. I think my investment has also encouraged my parent, whose job is mostly sedentary, to be more active. They've now begun their own fitness challenge too." And another student has said, "I'm a lot healthier now physically and mentally. I exercise regularly and watch my diet, and the amount of sleep I'm getting has increased." And finally, a further student has said, "It's required me to think of doctors as medical students in the future, and the idea that we too can easily be patients." And to me, this last quote is all about highlighting how students recognise themselves as future practicing clinicians and the importance of LMAP in encouraging students to think about their well-being, not only during medical school, but lifelong going into their future practice. Next slide, please. Although there has been a lot of positive take-homes from the medical students and what they've shared, I think it's important to acknowledge that there also has been a lot of challenge and uncertainty brought out through the topics discussed in LMAP. Some students have recognised that, especially in hospital settings, often due to too many missed opportunities, it can feel difficult to make a difference for patients. Others have questioned what the role of a doctor is in lifestyle medicine, in that they're limited in their sphere of influence in terms of the wider determinants of health. I don't feel discouraged by these comments, and instead see them as valuable opportunities for discussion and reflection with the students. And I just want to finish with this last quote, which I personally think is quite powerful in encapsulating how LMAP has provided a new perspective for medical students. In terms of how LMAP has changed my outlook on health, I would say it showed me how the doctors aren't necessarily the most important people in health. I don't know how to put that better, but they're not as important as you think in terms of health as other factors. Because in LMAP, we learned that 60% of health is the wider determinants and 20% is healthcare. And I think I always thought that in the UK, we have the NHS, everyone has an equal right to good health. Ultimately, the student is demonstrating to me a fundamental shift in how they view population health and the role of a doctor. Next slide, please. So briefly, I just wanted to mention some personal reflections from this year. I'm really grateful for this really unique opportunity for an immersive insight into public health, especially for someone like me who's relatively junior in my career and not in specialty training. It's been a fantastic opportunity to combine my interests of population health, student wellbeing and medical education. The role has required a lot of introspection on my clinical experiences to date. I've had to reflect on how I've had my personal challenges of maintaining positive lifestyle behaviours whilst working clinically, and also communicating population health to students who've had limited clinical exposure has also required a lot of reflection on how population health intersects with clinical practice. Looking ahead, although the feedback from the students has been encouraging and many have demonstrated positive behaviour changes, it will be interesting to see if these persist throughout their medical training and into their careers as doctors, and it's important we explore this further. Overall, I'm really grateful for the opportunity to be an LMAP Fellow and be part of such an innovative module. So thank you very much to the whole team who've worked on LMAP. Thank you.